John Macaskill, welcome to the Nuffield Trust. You're Chief Executive Officer of Midlands Health Network in New Zealand. Can you tell me a little bit about your organisation and its origins?
Sure. Well, look, Midlands Health Network, it's a group of GPs. We're based in the middle part of the North Island, so there's about 100 practices, around 350 GPs, 400 or so nurses. And look, it's got its history back in the late 80s, where a group of GPs were concerned about, I guess, professional isolation, you know, practicing in a small practice, not having the opportunity to get together with colleagues, concerns around the variance and quality kind of issues. So a group of them tell you a very long and detailed story about getting in an old station wagon and driving around and visiting their colleagues and having too much beer and wine on the way, I think. But from that they formed an organisation which has evolved over the years now into, you know, a substantial part of the New Zealand health infrastructure. And I think an organisation that from a primary care perspective is really driving a very strong agenda around shifting care closer to the patient and looking at patient journeys as opposed to clinician-dominated journeys. So starting to better understand how can people move through a system, how can people understand the system, and how can the primary care clinicians kind of be their advocate with that journey.
And this is a network, like many others, that's owned by the GPs. Tell me why that's important and how the governance works of that.
Yeah, it is owned by GPs, and I think that is important in the sense that there is a real stake in the organisation. Now, there's the huge variance you get with any group of people. So you have the early adopters who are really keen on doing things differently. But the other role that the organisation plays is also sometimes people get concerned around government changes, and in New Zealand we've gone all over the place. Every 3 years things get tossed up and shuffled around. So the GP network or group, as it's been, has been able to maintain a stable kind of view and a stable kind of sense for general practitioners, and that's been really important. And it's been their organisation; it's not a government organisation. So, you know, occasionally we've had to stand up and say no and take very positional views on different items or agendas that the government were pushing, where at other times, you know, and currently in the current conversation, we're really designing the agenda in partnership with the government. So I think it's the sense of buy-in, the sense of ownership, and that sense of independence that, you know, a lot of GPs are GPs because they didn't want to work in a hospital. They wanted to have the autonomy to practice clinically closer to home for people, have an ongoing relationship with the people that they're looking after, but this gives them the ability to also be part of something a bit bigger.
From a patient's point of view, what does organised general practice mean? What does a network mean for them?
Well, look, on some days I think nothing. You know, they go to their GP, they have a sense their GP is part of a larger health system. And often, you know, patients are quite surprised at how siloed bits of the health system are. Particularly, you know, if you take, say, health information, you know, most consults, whether with a GP, a nurse, or even a hospital specialist, involve a computer. And I know that recently we had the conversation with a lot of patients, and they just assumed that it was the same information that was being passed between all the players. But I think what the networks have meant for patients is a sense of greater consistency, so that you know, we've put all the practices through an internal quality program. We're in year 15 of that, which it's been designed and governed by the clinicians themselves, but they're always proud. And it's interesting when you go into to notice where practices hang the certificates and stuff, particularly as some of them started to hit the 100% kind of mark. And from a patient perspective, that will have introduced greater consistency. So that will have raised the minimum standard in terms of the facilities and how they operate, but also around how well the staff within the centre are trained and the breadth of services that are available.
How has the network worked with partners beyond primary care, in other community services or particularly hospital services?
Yeah, that's an area that we've had some good false starts, but we've also had some good wins as well. And I think in the present political environment where we're all faced with the economic kind of squeeze, there is now a real willingness for things to happen quite differently. So we've actually moved into a shared risk holding contract between the local hospitals and GPs, but also some of the allied providers, particularly say community pharmacists. And what we're doing is collectively sitting around the table looking at key areas, whether it might be a disease state or it might be about particular access issues. And rather than, the typical thing is that general practice will look at the bit that they can deal with, actually collectively looking at the whole patient journey and then looking at how it can be streamlined from a patient perspective. Now, what we've found is that we've been able to bust through things that we've talked about for years in a matter of months.
Is this alliance contracting you're describing?
Yeah, it is alliance contracting.
Can you just walk me through how
it works? Well, it comes from the oil and construction industry, where I think you have multiple parties working in complex projects. And there's a lot of, if you read the evidence, a lot of evidence, if you make everyone accountable, then, on time, on budget, on everything else seems to be that you have a much higher chance of that kind of outcome. So that's what we've done. So we've taken the total budget for a population, put everyone around the table who's got some accountabilities around that, and requiring them to work together. And I think, one example around an acute MI, we mapped out the patient journey from home through into hospital, and immediately it was really clear there were hundreds of steps and processes that, either clinicians, patients or administrators went through to manage that patient journey. And I think, there was 46 steps that within minutes of having everything on the wall, everyone collectively agreed we'd grown up with it, that's what we did, but they actually added no value from a clinical perspective, and they just complicated the process. So I think that's kind of exciting, because usually we'd have a working group that would talk about this and write a paper that would pass it on to somebody else that would write another paper, form another working group, and then the government would change and nothing would happen. This was clinicians sitting there going, crikey, with patients actually, going, this makes no sense at all, let's take those steps out.
But taking some of those steps out must mean less income, less revenue for some organisations. How does this alliance contracting, in a sense, manage those tensions?
Yeah, I think the thing that we've got in the New Zealand system is that we've got primary care operates slightly differently from secondary. So secondaries are totally capitated public service. And the joke in primary care is that often if we make a saving, it's a black hole and it just gobbles up because there's always an overspend somewhere else. Whereas primary care is still essentially in private ownership, private equity owns it, and it's also partially funded through patient co-payments. So yeah, there is a bit of a gap that we're having to join, but typically the cost of provision in community and primary settings is significantly lower because it doesn't have all the overhead kind of costs. So some of what's happened as a result, in that example I used there, there's been a tremendous efficiency gain by shifting things around with collective agreement, and that's resulted in the savings. And what we've been able to do in the alliance is actually ring fence those savings and reinvest it in supporting those services, rather than letting that black hole syndrome kind of gobble up any savings that you've come up with.
But is it reinvested across? I mean, does the hospital lose out? Because this is the problem that we face here in the NHS, is that some of these changes mean losing jobs at hospitals, and that's very unpopular obviously with the people who work at those hospitals, but it's very unpopular with the public who don't always get that the hospital needs to be smaller.
Yeah, I think the thing in New Zealand is that you need to understand that we just don't have the population density that the UK has. So if I think across the major hospitals that we operate, and one has a population coverage of 47,000, so it's a busy intersection here in London, where other ones are 500,000. Now, the smaller hospitals, they are a house of cards in terms of the volumes that are going through some of the specialties are marginal anyway to maintain, minimum kind of quality standards. But as you are pointing out, there is often a very strong emotional attachment to the hospital representing the health of the health system. So if the hospital's got all the services and you don't need to travel, say, to a larger kind of centre, then my health system's working well. So that is a bit of a challenge, and I have to admit, in the early days of the alliancing, it's the larger urban areas where we're getting the traction. The smaller rural district health board areas, we're still talking about it.
Can I ask you for your observations, having spent a few days here talking to people across this professional spectrum really about the opportunities that are opening up in relation to clinical commissioning, which is still going to be very much, we hope, GP-led?
I would say I think it's from the top down perspective, there is a very interesting opportunity and suggestion being put on the table. I'm not quite sure the system's equipped and quite got what that is or how big that is. Now, if you came down to New Zealand and put that offer on the table, we would gobble that up and I think make some really interesting changes. So, yeah, I guess the challenges need to get some infrastructure developed in the primary care setting that isn't PCT, that is more clinically led, but has that level of sophistication that can model up and really make some of those tough calls around where services need to sit and how they need to look.